Good evening, ma'am.
Yes, Abhilaksha. Good evening.
Good evening. Good evening.
Good evening, Ratnam.
Good evening, sir. How are you, sir?
I'm fine.
Good evening.
Hello, Ratnam. Nice to
Thank
see
you,
you.
sir. Hello, sir. Nice to see you, sir. After so long.
Yeah.
Sir, we are live.
Yeah, we are online.
A very good evening to all. Myself and Dr. Partho are happy to moderate this fiery webinar on inflammation today evening. We thank the office bearers for the opportunity and for organizing this very practical session on uveitis. We welcome you to this webinar on walk-in patient, what to think of, how to triage, and how to manage. Though our chairpersons don't need any introduction, it's my proud privilege to introduce the teacher of teachers, Padma Shri Professor Amol Gupta, Professor Emeritus, PGI Chandigarh. The powerhouse of knowledge and teacher of teachers, Dr. Jyotirmay Biswas, Director, Uvea and Ocular Pathology, SN Chennai. The silent crusader and teacher of teachers, Professor Ratanam Shivakumar, Director, Uvea Services, Arvind Eye Hospitals, Tamil Nadu. The one and only, very inspiring, Professor Vishalti Gupta, Head of VR Services, PGI Chandigarh, and President of the International Uveitis Study Group. I also welcome our outstanding speakers for the evening, the students' favorite, Dr. Padmamalini Mahendradas, Director, Uvea Services, Narayana Nethralaya, Bangalore. Always to the point, Dr. Rohan Chawla, Additional Professor, RP Center, AIMS, New Delhi. And last but not the least, the dynamic Dr. Mudit Tyagi, Director of VR Services, LVPI, Hyderabad.
A very warm welcome to all. I now invite Dr. Padmamalini to present her talk on anterior uveitis. Don't think it is so simple. Over to you, ma'am.
Respected chairpersons and dear friends, very good evening to all of you. At the outset, I'd like to thank AOS team for inviting me here today to speak on anterior uveitis. Don't think it is so simple. Anterior uveitis is commonly seen in a practice. As per the Sun developing criteria, the causes could be secondary to infectious etiology or associated with systemic diseases or diseases limited to the eye like Fuchs uveitic syndrome. We'll move on to the case examples. The first case was a case of recurrent anterior uveitis. Whether it was a TB or sarcoid or something else was the dilemma. Let's see the case now. 61-year-old male presented with diminution of vision, pain and redness in the right eye since 1 month. He had recurrent episodes in the past. 2 such episodes was treated elsewhere with topical steroids. He presented to us in October 2023. That is the current episode. On examination, the visual acuity in the right eye was 624 parts and N18. The left eye visual acuity was normal. Intraocular pressure and examination of the left eye was within normal limits. Coming to the right eye, he had small KPs centrally and large KPs inferiorly with a prominent corneal nerve. Also had AC reaction associated with copious nodules. Vitreous haze was 1 plus. Apart from that, the posterior segment was within normal limits. He carried these investigational reports in that hemoglobin was 10 grams, ESR was increased, MAN2 was positive, quantiferon was indeterminate, and serum ACE was borderline, that is 68 units per liter. Coming to the systemic history, he gave history of tuberculosis in childhood and he was treated with ATT, hypothyroidism for 10 years on thyroxine, no case of CKD, at present not on any treatment. On systemic evaluation, he had prurigo nodularis. He was treated by the dermatologist in the past. He also carried HRCT test results. In that, there was no evidence of TB or sarcoid. However, in the result, they mentioned that there was a small contracted kidney on HRCT. Based on this, we ordered the routine urine microscopy, serum creatinine level, and also urine beta-2 microglobulin and ANA and ANCA to rule out underlying systemic autoimmune disease. We did the confocal microscopy. We saw both immature and mature dendritic cells is very high, and we saw globular keratic precipitates. Urine routine microscopy showed 2 plus protein. Serum creatinine was increased to 6.6 milligram per deciliter. Urine beta-2 microglobulin was above, that is 20,000 nanogram per ml, and other autoimmune workup was negative. So coming to the clinical picture, this patient had recurrent anterior uveitis, had chronic kidney disease with increased urine beta-2 microglobulin and serum creatinine suggestive of tubulointerstitial nephritis, anemia, prurigo nodularis with past history of tuberculosis. Coming to the classification criteria of tubulointerstitial nephritis, according to this, our patient had anterior chamber reaction, elevated urine beta-2 microglobulin, and abnormal urine analysis with elevated serum creatinine. Based on this, we started the patient on topical steroids, topical cycloplegics, systemic steroids. After clearance from the nephrologist and the rheumatologist, patient was started on oral azathioprine, 25 milligram once a day. Subsequently, the dose was increased. Follow-up, we could see the resolving uveitis in this patient with improvement in the visual acuity. Tubulointerstitial nephritis and uveitis syndrome, we call it as TINO. It's a rare form of anterior uveitis, thought to be immune-mediated, as evidenced in this case where we saw a lot of dendritic cells and definitive renal biopsy is the thing. But in our case, we had positive beta-2 microglobulin reduction on urine analysis and proteinuria. Based on this, we made the diagnosis. There was no treatment guidelines or no randomized clinical study in the literature. We treated this patient with topical and systemic steroids and immunosuppressive therapy. So we'll move on to the next case. Second case is a case of a severe fibrinous uveitis in a pregnant female following IVF treatment. Could it be endogenous endophthalmitis? Let's see. 28-year female presented with redness and pain and diminution of vision in the right eye since 5 days. She's 3 months pregnant on IVF treatment using estradiol valerate. History of ectopic pregnancy 1 year back, underwent laparoscopic intervention. She's high myope with nystagmus since childhood in both eyes. Anterior segment examination showed presence of circumciliary congestion, 4 plus AC cells, and fibrin exudates in the anterior chamber. The visual acuity is dropped and motion in the right eye. B-scan shows presence of anterior vitreous cells with normal posterior segment. This patient was started with topical steroids, did not respond by the primary ophthalmologist, and subsequently she was referred to us. So we did the complete hemogram, CRP, another infective workup, and also we did the AC tap since the patient did not respond to intense topical steroids to rule out microbiological infections. Laboratory investigation showed increased ESR and CRP level. AC tap showed gram-positive cocci. Urine and blood culture were negative. PCR is negative for both bacterial as well as fungal genomes. Patient was started on systemic antibiotics such as cefixime, topical steroid cycloplegics. However, there was persistence of inflammation. We suspected autoimmune. By then, we got the reports Procalcitonin was normal. Actually, B27 by PCR method was positive. After consultation with the gynecologist and the physician, we started on low-dose systemic steroids. We continued the systemic antibiotic and topical steroids. For day 4, we could see the resolving fibrin exudates in the anterior chamber. This is day 8. There's complete resolution of the fibrin in the anterior chamber with normal posterior segment. So this is OCT showing the appearance of fibrin in day 1 and resolving exudates in the anterior chamber. Coming to the classification of HLV-B27 associated uveitis, our patient had anterior chamber reaction and also the anterior vitreous cells was present. It was acute presentation, unilateral presentation in association with HLV-B27 positivity. Usually it presents with unilateral non-granulomatous severe inflammations associated with hypopyon and anterior chamber fibrin. And they respond to topical and systemic steroids. In other individuals, we do start them on systemic immunosuppressive therapy or biologics, but not in this pregnant lady. Next, we'll move on to case 3. Is it just anterior uveitis? More than meets the eye. 34-year lady, known case of chronic anterior uveitis, currently an acute episode of anterior uveitis in the left eye. She also gave history of non-specific bilateral knee joint pain few months ago and started on oral hydroxychloroquine. On examination, right eye was absolutely fine. In the left eye, we could see circumciliary congestion, AC reaction, posterior synechiae. There was a prominent corneal nerve and central white capes in the left eye. Fundus examination showed grade 1 vitreous A's in the left eye. Apart from that, it was within normal limits in both eyes. We made the diagnosis of non-granulomatous anterior uveitis in the left eye, started the patient on topical steroids and cycloplegic agents. We ordered the routine investigations. Most of the workup, including the autoimmune, was negative. Confocal microscopy showed infiltrative pattern of keratic precipitates with few pigment clumps in the left eye. In view of vitreous A's, we subjected the patient for fluorescein angiography, which showed diffuse perivascular leak in the left eye with disc staining, the normal angiogram in the right eye. Based on the white capes on endothelium, confocal showed infiltrative pattern of capes, and FFA showed perivascular leak. Based on this, we wanted to rule out infective etiology. So we did the ACTAP for PCR, for viral genome, and quantitative PCR for CMV came positive with 193 copies from the aqueous humor in the left eye. We started the patient on both topical as well as systemic valganciclovir, along with topical steroids and cycloplegic agents. 1 month follow showing resolving keratic precipitates. This is 3 months follow-up. By that time, we could see only the pigment deposits on the anterior lens capsule. The patient had stopped the systemic valganciclovir therapy. There was a resolved capes, and confocal showed resolution of a capes with pigment clumps. This is a fundus photograph at 3 months. The angiography shows resolution of a fluorescent leak in the left eye. CMV anterior uveitis is commonly occurs in immunocompetent individuals, and they do respond to systemic or topical valganciclovir therapy. There are 2 reports in the literature shows posterior segment involvement with CMV iridocyclitis in an immunocompetent adult, both by Wong M. et al. And Sakai et al. Here we have treated the patients both with systemic as well as topical valganciclovir therapy. In summary, we presented 3 cases. First case is a case of a Tino with tuberculosis treatment in the past, responded to steroids and immunosuppressive therapy. The second case is a case of HLV-B27 associated uveitis with pregnancy. Here, the infection has triggered the inflammation. In pregnancy, most of the times the flare-up occurs in the first trimester or in the immediate postpartum period due to dysregulation of Th1 and Th2 pathway. The third case is a case of a CMV anterior uveitis. We suspected because of central white capes and confocal pattern in spite of being the normal intraocular pressure. PCR helped us to confirm the diagnosis with occult posterior segment involvement, and patient responded well to ganciclovir therapy. To conclude, Anterior uveitis, it's not so simple. Rethink anterior uveitis. See beyond the simplicity. I would like to acknowledge the team members for the contribution. Thank you for your attention.
Thank you so much, ma'am, for the eye-opener cases. I'm sure the general ophthalmologists who are seeing this program will benefit from these cases. We'll go on to the discussion. Dr. JB sir, for a general ophthalmologist, when they do not have access to PCR or confocal microscopy, how would you, what all to look for?
I think I would go starting from the history. And I think first thing first, like, that first case is that elderly people, and I would not have really thought that it could be Tinu. I would have done that investigations, the basic investigations first, like, HLA-B27, and I would not have thought of doing a urinary beta-2 microglobulin in this case. So that was a very eye-opener. It came as we have reported one case of Tinu in a small child who was a biopsy proven. That case, that nephritis came first, and then the patient developed uveitis. So this is I think is most of the times we CMB anterior uveitis. I don't think that you can establish the diagnosis looking at the clinical picture alone, and it would not be wise to put the patient on ganciclovir therapy based on the clinical suspicion like coin-shaped keratic precipitate, etc. So where the PCR, if it's not available, I would refer to a center where the PCR facility is available. Third case is that endogenous endophthalmitis.
Yes, sir. So there is one question from the audience.
Please.
No, yes, sir. Please continue. Please continue.
Yeah. The HLA-B27, the third case is the AC tap was done in that in the HLA-B27 positive uveitis also can have significant vitritis. So we need to treat with that kind of a topical treatment first, and then if not responding, then only we'll think of doing the SC tap and or vitreous biopsy if it is needed. Sometimes the endogenous endophthalmitis and severe HLA-B27 panuveitis can mimic each other. These are my thoughts.
Thank you, sir. Just one more question from the audience. If one treats with oral valganciclovir, how does topical ganciclovir provide additional benefit?
Here the patient had, normally what we do, we start with anterior. If does not respond, then we add the oral. So basically, like, it's not the other way. When you give systemic, not necessary that you don't have to give topical. We give combination of both. Many times, like, some patients, they do respond to topical alone, where we don't have to put the patient on oral valganciclovir, but the percentage is less. Since the inflammation and the CMV is in the anterior segment, topical definitely has a penetration into the anterior chamber.
Yes. Thank you, ma'am. Dr. Amod Gupta, sir, would you like to comment on the cases?
Yeah, I think Dr. Padma Malini presented some excellent instructive cases, I would say that. And as JB very rightly pointed out, the first case of Tinu syndrome, my own thoughts were that we see in children, like JB pointed out, and mostly these are seen as acute onset bilateral cases. So what we learn from Padma's case is that, well, they can be unilateral as well. And in a 61-year-old person, it's very unusual for ankylosing spondylitis or spondyloarthropathies to present first time with acute anterior uveitis at the age of 61 years. I mean, that is rather unusual. And as she rightly done the systemic exam, there is a history of tuberculosis. She has kept differential of sarcoid, syphilis. I would have thought of syphilis, certainly. But as he said, Tino would be a little far-fetched idea in this patient. But she rightly did the systemic investigations, got to see the renal involvement. So whenever I see patient of uveitis, I am worried about the kidneys. You know, kidneys and eye are both closely linked. And she rightly pointed out that kidneys were small. There was albuminuria, so she did that, microalbuminuria, beta 2 microalbumin. So that, I think, won't occur commonly to a general ophthalmologist. And for them, my advice would be that if the patient did not respond, refer to a uveitis expert. The second case was the acute anterior uveitis in a lady who has undergone procedures in the recent past, has undergone IVF. So she rightly thought of endogenous endophthalmitis. I would have thought the same. In fact, the first case of acute anterior uveitis, which I experienced when I was a junior resident almost 50 years ago, was a patient, young man who was admitted for enucleation of the eye because we didn't know how to treat endogenous endophthalmitis at the time, enucleation. And I just for a lark, I thought, let me put atropine drops and corticosteroid drops. And by the time it was late evening, the pupil had started dilating and the exudates had started shrinking and the patient started seeing. And, I was so excited. Here was a patient, destined for enucleation. And here is what, I could save that eye. So that was very exciting. And I think for a GP or a general ophthalmologist, that would be the advice. If you don't know what you are dealing with, no harm in treating with atropine drops and corticosteroids topical. No harm would be done if you have ruled out a viral corneal ulcers. So that would be a safe approach and see how the eye responds. And the third case, I think CMV uveitis, well, it was unilateral case, had Seneca, had KPs, but had no raised intraocular pressure. So that was something dicey. And for general ophthalmologists, because this is, if you see the SUN classification, SUN 2 classification, so CM anterior uveitis, the diagnostic criteria is a raised intraocular pressure. So that is where we start suspecting. But what I would think of starting the conventional treatment with corticosteroids and atropine drops. And if the patient is not responding, you're treated acute anterior uveitis, patient is not responding, that becomes an indication for doing a PCR. And when we are doing PCR, then we do because it might have been HSV, it might have been maybe not as common VZV, but it could certainly have been CMV. So we non-responding patients, even if we had put him on valcyclovir, for instance, and he was not responding, I think before doing valganciclovir therapy, which is an expensive treatment, I think a PCR is in order to rule out a resistant HSV, VZV, as well as detecting a CMV. Of course, these are uncommon cases. A general ophthalmologist unlikely to come across, or maybe once in a lifetime, come across a patient like that in their practices. But if the patient is not responding, the message I would like to convey is to the conventional treatment, which is a simple, straightforward topical therapy, the patient must be referred to, if you do not have any other differential diagnosis that you can exclude by your simple lab test, would refer to a uveitis expert. And now we have all across the country, fortunately, uveitis experts available within maybe distance of 250 or 400 kilometers. So it should not be a big deal, good connectivity, rather than sit on these patients which may have adverse outcomes and you don't know where to go then. Yeah, thank you.
Thank you so much, sir. We go on to the next presentation from Dr. Mudit Tyagi.
All right, first of all, thank you so much for AIOS, Abhilasha, Dr. Partha, and everyone for having me here. And I'll just be sharing my screen. Yeah. So are my slides visible?
Yes.
Yes. So I will be talking about what to do when a patient with floaters walks into your clinic and tells you, doctor, I see a lot of floaters, what may be wrong? Now, what we need to remember is the fact that a floater may be innocuous. So there can be multiple reasons for you to have a floater. A floater may be totally innocuous. It may probably just be because of the fact that a PVD has occurred, a posterior vitreous detachment. So your patient may have a PVD. So it's important to be aware of all the various possibilities that a floater can lead to and can signify, from something absolutely harmless to something absolutely sinister. And that's why you need to look at the eye, look at the patient, examine the patient very clearly. Uveitis, I believe, is that branch of ophthalmology which requires more an application of all principles of medicine than anything else. You need to be aware of the systemic things that your patient is dealing with, the entire history of the patient, all the disorders, and that will help you. So good history taking, a good complete examination of the patient as a whole, I think is integral to the practice of understanding uveitis. So for all that you know, it may be a retinal detachment that has happened, and now you see something which people otherwise describe as tobacco dusting, but are RP cells, pigments which have come into the eye. So a sudden onset of floaters may actually be a herald of a break and a retinal detachment. You may have a patient who's otherwise diabetic, and the sudden onset of floaters may be nothing but an onset of a vitreous hemorrhage. So there are multiple possibilities that a floater can point out to. It can be just old vitreous cells. Your patient had uveitis which is healed, but now the patient has suddenly got a PVD which has happened, and now those floaters which were lying around those old vitreous cells are now suddenly in the visual axis, and the patient perceives it for the first time. So while these may sound to be non-uveitic, you can also see floaters because they may herald an active inflammation that has occurred. In a patient who has had a VKH, suddenly new onset floaters may be a sign of the fact that there is a recurrence. So most importantly, take a meticulous history, talk to the patient, check both the eyes of a patient, and let me show you a few cases. So this was one patient who came to the emergency clinic with a sudden onset of floaters, had a relatively spared visual acuity because the fovea was not that much involved, vision was 20/50, but a careful examination revealed this large retinal detachment with this large break superiorly, lattices and multiple breaks. So in this case, floaters helped us in picking up a case of a retinal detachment early and starting this patient. Similarly, if you see a picture like this with a patient with a history of a vein occlusion or diabetes or any vaso-occlusive disorder, these are patients who require treatment, and sometimes the reason they present to our clinic is because they see something floating in the eye, which is nothing, vitreous hemorrhage. So as ophthalmologists, we need to keep all the possibilities in our head when we see such patients. However, floaters, as we all know, can also be a sign of inflammation. So this was a patient who came to us with this significant multiple pigmented KPs. And you can see this small lesion over here. And this was a patient who had a toxoplasma. The vision still was relatively not that bad because of the fact that the fovea was not that much involved. But the point is that the patient had floaters, had signs of inflammation, and a retinal examination revealed the presence of this toxoplasma retinochoroiditis in the right eye, a healed scar in the left eye. So this is another patient where you can see a retinochoroiditis lesion over here, and you can see not only see that clinically, but an OCT reveals all of these cells which are there clinically. So again, floaters were the presenting reason why this patient came to the clinic in the first place, and a retinal evaluation led to the detection of a toxoplasma. So I'm just showing to you multiple scenarios of how floaters can present with and what they can lead to. Another case, one more case where you can suddenly see a dense vitreitis is patients of acute retinal necrosis. In fact, for all patients, it's important for all the ophthalmologists to be aware of the fact that 2 or 3 of the most common conditions that present with a dense vitreitis may be toxoplasmosis, acute retinal necrosis sometimes, and pars planitis. And also I'll come to one more example. So a patient came to us with floaters, retinal evaluation revealed the presence of these multiple retinitis lesions confluent in the periphery. This was a case of ARN. So this is another lady. This came to us with a vision of no PL in one eye. She was a non-Hodgkin's lymphoma patient, and she also had this lesion in the other eye, and that led us to diagnose this patient as having a CMV retinitis in a patient of non-Hodgkin's lymphoma. That's why it becomes important as an ophthalmologist to look at both the eyes of the patient and how you can pick up clues from one eye which can help you in diagnosing disease in the other eye. Patient was started with ganciclovir, and this is how the patient responded. We were able to salvage vision in the right eye. The left eye was lost because of optic atrophy. Another patient actually presented to us with decreased vision in both eyes, had initially been treated with systemic steroids, turned out to have these multiple miliary lesions, was a case of ocular syphilis. And just few minutes back, Dr. Amod Gupta sir was talking about syphilis. And remember, syphilis is such a big masquerade. We check for syphilis in every single possible patient who comes to our uveitis clinic. So get a triple test TPHA done for all of these patients, because TPHA or the triple tests have got a sensitivity of more than 90% as compared to non-triple like ones like VDRL, which have only 70% or so. So consider syphilis as a differential diagnosis of every possible manifestation of uveitis. So when we did an OCT, we found this full thickness miliary lesions for this patient, and this was another patient who was a known case of vasculitis. Now suddenly comes to us with sudden onset of floaters, and this patient had got occlusive vasculitis, now had also got an amount of vitreous hemorrhage, was subsequently treated with pan-retinal photocoagulation. So the point is that these floaters can be a herald of different conditions. And now if you see a patient who comes to you with a sudden onset of floaters and decreased vision, and a patient has got a past history of any intraocular surgery, this was a case of cataract, that is then a herald of something extremely sinister. This was a patient who had developed a post-operative endophthalmitis. So occasionally patients may come to you just with a increase in floaters, and if that is the case, again you need to look at them. In this case it was a full-fledged endophthalmitis, but sometimes you may be lucky enough to have these patients presenting to you very early, and you may just be able to diagnose them at a very initial nascent stage. And that's why it becomes important to take a history. A patient post-operatively comes to you with a sudden onset of new floaters, think of the possibility of a possible endophthalmitis. They can also be a manifestation of an anterior recurrence in cases of VKS. So you may have posterior segment recurrence, but sometimes these patients in the chronic phase may just come to you with increased inflammation and AC cells. One more condition where you may see a patient coming to you with floaters, and that is Fuchs uveitis. You may see these multiple fine stellate capes, no synechiae, and no cystoid macular edema. Also, it becomes important for us as ophthalmologists to counsel these patients about when they undergo a cataract surgery, because now when their visual axis becomes clearer, they start perceiving these floaters more, and they get disturbed by those vitreous opacities much more than what they probably were. And therefore, as ophthalmologists, as they're operating cataract surgery, it becomes important for us to make them aware of this fact that they may probably now perceive floaters more than what they were perceiving. So in a nutshell, I will just sum up my talk by saying that take a meticulous history, look at both the eyes, be alert to all the possibilities that a floater may be indicative of, and do a good systemic complete evaluation for these patients. Thank you so much. Now with that, I'll stop my slides.
Thank you, sir, for showing us the extensive causes of floaters. I now invite Professor Vishali Gupta for her comments, ma'am.
I think Mudit has put it very clearly that floaters can be something which can be seen in any form of uveitis. It could simply be a sign of anterior uveitis. It could be in Fuchs uveitis. It could be in active posterior uveitis, like he showed beautifully on anything which produces cells in the vitreous. And intermediate uveitis is actually one of the commonest ones. Before it produces cystoid macular edema, you may just complain of floaters. It's also important not to ignore floaters when the patients are during follow-up, especially heel TB patients, because they may be first sign of vitreous hemorrhage, or sometimes they must just be the first sign for retinal detachment in otherwise healed lesion. So I don't think I will particularly pay a lot of attention to floaters as a specific sign for any disease entity. So like Mudit said, once you have floaters, do a detailed examination. And sometimes I see that floaters automatically people start looking at retina and do not even do slit lamp exam, typically in the retinal settings. So that is very important because somebody with, like Padma showed, those CMV, they are not obviously uveitis. You don't have pain, redness, just few floaters. You do indirect, you may see PVD and you attribute it to, and you may miss subtle signs. So I think the key is to do a good slit lamp examination and fundus examination to find the cause of floaters. And if your patient is on follow-up, then floaters remain one of the signs to review SOS.
Yes, ma'am. Just one question from the audience. Do you advocate vitrectomy for innocuous floaters troubling a patient?
This is a very interesting question because when the patients come, they generally complain that they're really bothered. Then I tell them, okay, we do vitrectomy, floaterectomy, but these are the pros and cons. And now you decide. And then they say, nahi, abhi itni problem nahi hai. When they, when you explain them the surgery and the risk. So I generally do it. I do floaterectomies for the patients where the vitreous is intensely and they are really bothered. But by and large, once you talk to them, 90% of the patients themselves back off the surgery. So.
Thank you so much.
That's the most important message which ma'am gave, to have a good dialogue with the patient to make them understand the pros and cons.
Yes.
There will be some patients, specifically the ones who have had a healed uveitis, where they will be having these debris sort of a thing floating in the eye, and they respond miraculously to a vitrectomy from 20
and
to
they're very happy after vitrectomy.
Yeah, after
Those
that.
who undergo are very happy. But you have to talk to them.
Yeah, but the most important point is a good dialogue and explaining to them the pros and cons, and then let them choose.
Yeah.
And sometimes sometimes we'll even meet a patient of lymphoma with intraocular lymphoma. So unresolving, especially white cells, uniform cells, and sheets of cells, vitrectomy may help when it is not responding to other treatments.
Thank you, ma'am. Thank you. We'll move on to the next speaker, Dr. Partho. I invite you to speak on decoding red or white, challenges in treating children's eyes.
Thank you. I'll just play the video so that I can finish on time.
Good evening, everyone. Topic of my presentation is decoding red or white, challenges in children's eye. In this presentation, we'll discuss a few cases of pediatric uveitis and try to decode uveitis in red eyes, in white eyes, and interestingly in deceptive eyes in children. So let's start with the white eye. I'll show you two cases. A 5-year-old child was brought to our clinic by his parents when they noticed white spots in the left eye of the child. The parents denied any history of redness, eye pain, and joint pain, and they were not using any medication when they presented to us. The second case is of a 9-year-old girl who was complaining of mild redness in her both eyes. She was being treated as allergic eye disease with on and off use of topical steroid, and the girl was also complaining of pain in her both knee joints. Both the child had active inflammation in eyes, developed synechiae, band-shaped keratopathy, cataract, and the girl was a steroid responder and developed a high intraocular pressure in both eyes. The right eye was 28 millimeter of mercury, the left eye was 32 millimeter of mercury. Both the children had actually juvenile idiopathic arthritis. So we sent both the children to rheumatologists who started oral methotrexate in the first child, whereas in the second child, he decided to start subcutaneous adalimumab with oral methotrexate. So learning point from these two cases are that the children can have active uveitis without or with minimal congestion. In absence of other symptoms such as eye pain, photophobia, watering, such cases can be missed. Also, sometimes this can be mistaken as allergic eye disease. The second, one should rule out JIA in all cases of chronic anterior uveitis in children, and absence of joint pain does not exclude a diagnosis of JIA. Third, not topical steroid. It is the systemic medications such as methotrexate or adalimumab that should be used to achieve long-term control of inflammation in these children. And one should refer these children to rheumatologists for complete evaluation. Our third patient is a 10-year-old boy who presented with diminution of vision in right eye. Like the first two cases, his parent also denied any previous history of redness, irritation, and eye pain. He visited a nearby optician and was prescribed glasses. When there was no improvement with glasses, then they decided to consult a doctor. The slit lamp examination showed inflammation in anterior chamber and anterior vitreous of both the eyes. Fundus examination of the right eye showed vitreous hemorrhage and the left eye, which was apparently normal according to the patient, who showed peripheral retinal vasculitis with pars plana exudate. So this was a case of pars planitis, which is common cause of uveitis in children and often manifests as white eye uveitis. Now, what we learned from here, that the examination of both eyes are crucial. Many uveitic entities in children are bilateral, so don't neglect the other eye. Second, examination of retinal periphery or pars plana in children is often difficult, especially in presence of band-shaped keratopathy, synechiae, or cataract. But one should carry out a detailed examination if required under general anesthesia in these children with suspected uveitis cases. Also, one must remember, if not treated early, the retinal vasculitis and the pars planitis can lead to vitreous hemorrhage, as there are frequent chances of developing retinal neovascularization, and there are chances of tractional and or rhegmatogenous retinal detachment in these children if the pars planitis is not treated early. Also, the vitreous hemorrhage in children is much more common than in adult with pars planitis, with one study showing the difference as 28 versus 6%. Red eyes are very common manifestation of acute or hyperacute causes of uveitis in children, and the list is long. I won't go into the detail of each cases, but one must remember that any uveitis that can occur in adult can occur also in children, but with some unique entities which are specifically seen in children. For example, Blau syndrome, Kawasaki disease, tubulointerstitial nephritis, and uveitis syndrome. So one should know about these cases so that they can clinch the diagnosis. I'll show you another case. A 12-year-old girl presented with history of redness, minimal ocular pain, and irritation for 15 days. She was elsewhere diagnosed as allergic conjunctivitis and was using a lot of medications. So when we examined her, we could see the late edema, which was more marked in the right eye than the left eye, and there were discharges in both the eyes. And there was some congestion of the deeper episcleral vessels with conjunctival hyperemia in the right eye and occasional cells in the anterior chamber. So she was asked to continue the topical steroid and stop all other medication. She came back after 2 days with severe pain, headache, and the complaint was that she typically get the headache more at night, which was often waking up from the sleep. So this is a photograph. I'm sorry, because this photo was taken by the father in a mobile camera. So her fundus examination revealed retinochoroidal folds radiating from the optic nerve head to macular area, which was more in the right eye. Fundus fluorescent angiography was normal, but ultrasound showed the increased outer coat thickness. And at that time, we realized that we are dealing with a case of posterior scleritis. The child was started on methotrexate and the oral steroid in tapering doses. However, in two weeks' time, there was complete resolution of the pain, and her lead edema and congestion subsided, and the retinochoroidal fold disappeared. So what we learned from here, we must remember that the posterior scleritis is the most common cause of scleritis in children. In children, the posterior scleritis may present with proptosis and conjunctivitis-like signs and may pose serious diagnostic challenge. Now, our last section is the deceptive eye. These are the cases where you intend to miss severe life-threatening malignancies, which is commonly called muscularite. So a 5-year-old boy presented with a gradual painless diminution of vision in the left eye. He was being treated elsewhere as a viral uveitis, and so there was a delay in the referral. The slit lamp examination, as you can see here, there was a floppy exudates in the anterior chamber. And when we did a ultrasound biomicroscopy, as all the investigations were normal, so we could pick up some moderate reflective seed-like echoes in the ciliary body region. So we decided to do a ACTAB, which showed the malignant cells, and it was suspected to be a case of diffuse anterior infiltrating retinoblastoma, and an enucleation was done. The histopathology confirmed that this as a case of diffuse anterior infiltrating retinoblastoma. Thus, we can see here that sometimes the such children malignancies can mimic uveitis and can actually present in a different form. So to conclude, I will conclude with 5 take-home points. The first, beware of white eye uveitis. Absence of congestion is not the absence of inflammation. Second, band-shaped keratopathies, synechia, cataract are obstacles for the detailed fundus examination. But fundus examination is must in children, and do not try to replace it with ultrasonography alone. The next must is the IOP measurement. The intraocular pressure measurement should be carried out in every children in every visit in a uveitis clinic. The fourth, the pediatric uveitis needs long-term control of uveitis, which is not possible with topical steroid or systemic steroid. Further, this medication can cause more damage in children than benefit. So always think beyond steroid while managing uveitis in children. The last, beware of malignancies in children. Early detection of such entities can not only save the eye, but also life of the children. Thank you.
Thank you, sir. Thank you for the extensive talk on pediatric uveitis. I now invite Professor Ratinam to give her comments, ma'am, on the presentation.
It is a wonderful presentation. Biswas, Bhattam Biswas, you did wonderful job. And the last case is a phenomenon because few exudate, but it is a killing disease. So you were able to find out the masquerade cause of pediatric uveitis. I totally agree with you. The white eye uveitis is very, very dangerous because unfortunately we are not having proper screening, school screening program, especially in remote villages and suburban areas. At least urban areas nowadays we have school screening program. And also, when the patient has joint pain, the rheumatologists do not send the patient routinely to ophthalmologist. So many times they come with band-shaped keratopathy, they come with ring synechia, they come with secondary glaucoma and opaque vitreous. So it is a big challenge. Probably more and more we have to have collaboration with rheumatologists, making them understand that they have to send the patient for ophthalmic screening. It's a very good presentation. Thank you.
Thank you, ma'am. So next we'll go to our next speaker. So our next speaker is Professor Vishali Gupta. So she will be talking on many cases of choroiditis, how to sort it out. Following that, we'll take a quick bite from Professor Amod Gupta. Over to you, ma'am.
Thank you, AIOS, and thank you, Partha, for the very kind invite. The topic which Partha has given to me is many phases of choroiditis, how to sort it out. Well, for a comprehensive ophthalmologist, I see something yellow in the fundus, which I believe could be choroiditis. I think before we go on to labs or imaging, there are few questions that one must answer. Is it unilateral or bilateral? What do you think is the anatomic location? Is it retinal or is choroid involved a part of retinitis lesion, or is it primarily choroiditis? This could be done clinically, or it could be done with the help of OCT. What type? Focal, multifocal, diffuse, associated inflammation, any systemic disease, any past episodes. If there are, it's a good idea to take out those pictures. And finally, when you start treating, is the patient responding the way patient should respond to whatever therapy you are giving? So in nutshell, characterize the choroiditis. Now I'll show you this example. For example, this patient is a yellow lesion. So, as a comprehensive ophthalmologist, you may wonder what it is. Well, it's unilateral. It's mostly retinitis because it is fuzzy. And even if the choroid is involved, that is secondary to retinal involvement, it is focal, there is some vitreous inflammation, no disease, no past episodes. You do the OCT, you realize the inflammation is mostly in the retina and choroid is not really affected. So it is just toxoplasmosis because nothing else fits into this. So how do I sort it out? I just sort it out looking at it clinically and doing the OCT and not investigating further and just treating it. And you can see that with the treatment, you can actually avoid doing unnecessary investigations because it is not chorioretinitis, it is retinochoroiditis, and it is very obviously toxo. The second is now, again, I'm seeing something similar, but is it toxo? Is it choroiditis? Is it retinitis, or what it is? Now I do again the same thing again, and it looks to me it is choroiditis, but when I do OCT, this thing which is coming from the choroid all across the retina is going into the vitreous. Now, there is no inflammation of the choroid other than endophthalmitis, which will have this sign that we very classically call a rain cloud sign. So this patient had a rain cloud sign. It was invading into vitreous cavity, but somehow patient received steroids, and you can see within 48 hours now you have candida. Vitrectomy was done and it was actually candida, because the OCT gave you the clue that this is endophthalmitis and not choroiditis. The third case, actually patient had a slip carrying with him written multifocal choroiditis and a very common term, white dot syndromes. There is nothing honestly like white dot syndromes in uveitis, and that is the term which should be avoided at all cost. So what we see essentially multiple yellow lesions. So what would I do? When I look at these lesions, they do not look like choroiditis. There is no need to perform any investigations other than look at the autofluorescence and maybe OCT. So when we look at the autofluorescence, this shows a very classic leopard skin pattern. And I think the previous speakers also, one of them, Muddat, showed, this is the pattern which is very, very suspicious for lymphoma. So we advise the patient to undergo OCT, which showed lumpy, bumpy bumps in the RPE. And if you look at the cells, these cells are larger than the usual cells of inflammation. Anyways, we asked the patient for biopsy. Patient needed some time, and she came back a month later with a full-blown, what we call as primary vitreoretinal lymphoma, and these deposits can be seen. And now on OCT, this is a very classical rounded roof configuration. We have published it in OII that once you see the rounded roof configuration of subretinal deposits, it's highly likely to be lymphoma than anything else. And again, look at the character of the cells in the vitreous. So this is something which we see in primary vitreoretinal lymphoma. Of course, the patient underwent biopsy, which showed these cells. Now coming to the next form of choroiditis, which is very clearly choroiditis, where you do not have a doubt, and you may not even need to do OCT to tell you, because you look at it and you say, well, this is choroiditis. Now, this is an example of a 27-year-old male who has choroiditis, vitreitis. You can see peripapillary involvement. The lesions are multifocal, unilateral. Now, when we do OCT, we know it's primarily choroiditis, and patient also has scleritis. So looking at this, we know this is multifocal serpiginous-like choroiditis, which is how it looks like on fluorescein and ICG. The fluorescein is going to show you the lesions which are hypo at the edge becoming hyper, and ICG may show lesions which are hypo to hypo. These are the patients who need to be investigated to rule out the possible tuberculosis. The test for TB were positive. The CT had nodular, few lymph nodes, underwent EBUS, which showed tuberculosis. Patient is treated for that, response, and you can achieve recurrence-free almost more than 80%. The more sinister form of choroiditis comes in the form of a mass, a large granuloma in the choroid. Now, when we look at this granuloma, we kind of have 2 or 3 differentials, and most commonly tuberculosis is the one. Sarcoid also does creep into your mind sometimes, and the metastasis. For metastasis, it's very important to take the overall history, and if required, the whole body PET scan, and of course, the medical consult. Differentiating TB from other granulomas, including sarcoidosis, we do have some clinical clues. Now, if the granuloma is showing vascularity, it is yellowish in color, it is large, it is single, and it's really very prominent. This is more likely to be due to TB than to any other etiology. Now, this is just to show the example of a classical TB granuloma, which you see is large, single, produces some changes in the outer retina, and Mudit has spoken about it, published it, the contact sign, which you see the contact between the granuloma and the outer retina. These sarcoid granulomas, as we see in the bottom, are in the stroma. They are small, they are multiple, and when we see them clinically, they are not as obvious as you see TB granuloma, and they do not have retinal hemorrhages or vascularity. Now, if you look at the top, it is like TB. If the tests come positive, yes, I should treat them. If you look at this does not look like TB granuloma, so why would I treat it with TB? So I would rule out the sarcoidosis and treat it accordingly. As I mentioned, many of the patients with this form of retinal angiomatous proliferans on top of the granuloma or choroidal neovascular membrane are likely to be due to tuberculosis, because these granulomas are actually driven by VGF. So it's an important clinical sign. This is just to show the top TB and the bottom sarcoid, and I think I have already elaborated that. So this is like the algorithm which I follow. Like I look at the choroiditis. Is it diffuse? Is it multifocal? And if it is diffuse or it is unifocal, is it retinochoroiditis or is it mainly choroiditis? If it is retinochoroiditis, I showed the example of toxo or viral. These toxo may have some choroid involved secondary to it, but it is very typical phenotype. If it is a diffuse choroiditis, which is serpiginous-like, it could be autoimmune or it could be infective. Autoimmune, we do not see very commonly in India. It could be bilateral. There is no inflammation. Lesions begin in the juxtapapillary area and they are not multifocal. Here you probably can start steroid and investigate if patient is not responding. What we generally see in India is unilateral. There is associated inflammation in the vitreous and anterior segment, begins in the posterior pole, is multifocal, and you may have some associated vasculitis. Now, this is the phenotype which you need to investigate to rule out infectious etiology always. Choroiditis can be multifocal, which could have very classic phenotypes, and I'm not going to go into those mutes, ampy, PIC. So you don't need to investigate them. Only if it is not responding, you need to investigate. Phenotype could be atypical, where you don't understand. So this is the situation you always investigate. Now I'm going to show you two cases. The first representing why do we need to investigate the infectious etiology, and the second one representing why do we need to investigate when it is atypical. This is my first case. 29-year-old PhD student in the topmost institute of the country. She's working in an NTB lab. So she presents and is diagnosed as macular choroiditis. Given steroids with MMF, she was not even tested for TB. Now, if we look at this phenotype, we need to understand the pre-test probability of the various investigations that we are ordering. If we look at the context, the pre-test probability of this lesion due to tuberculosis is high, and if the test comes positive, she should have been treated. But she is treated with multiple immunosuppression, one after the other, and this is finally the stage when we saw her for the first time, where you can see that from the choroiditis, she's actually now gone on to develop a granuloma-like lesion at the edges. We looked for the etiology, the test for TB were negative. Finally, we found a focus in the parotid, and she said, oh yes, I had Warthin's tumor, and they did some biopsy. So we retrieved the reports, and it was the TB of the parotid gland. We did treat, but you can see the extensive damage that has been done, which could have been avoided had we diagnosed tuberculosis at this point of time, avoided multiple recurrences, which resulted in the permanent visual morbidity in a very young, active scientist. The last case, which I want to bring home a point that if there is something we do not understand and the phenotype is atypical, always investigate. Now, this patient actually came from very far off state in South India. So initially she was diagnosed as multifocal choroiditis. In between, somebody's written PIC, but she was carrying multiple diagnoses. And this was the left eye, which was full of vitreous inflammation. And there was Ozurdex in place, and she was on immunosuppressive therapy. So we did the autofluorescence and we found this lesion, and Mudit showed something similar. So my first thing was, oh, it's probably syphilis. And when we looked at we did the ICG, and ICG showed some dark spots in the choroid. And to be very honest with you, looking at the ICG, I could not put my finger exactly what it was. Did OCT through these small lesions, again, did not find anything of significance. So, like, my thought process was mostly syphilis, and I was wondering, has the left eye developed endophthalmitis because of the DEX implant? These were the investigations patient was carrying. PPD skin test was 30/25. No, TPHA was positive. Now, what is it? Would you treat for syphilis? Would you treat for TB? Honestly, this is not the phenotype I expect in TB, so I will not be very keen to treat for TB. TPHA positive, yes, I would treat her for syphilis, but when we repeated, both the tests came negative, though we did want to treat her for syphilis. And I was worried about the left eye, so I just first did the vitrectomy, cleared the vitreous, and found these pre-retinal deposits, which were aspirated. So we did the first op, post-op day. The left eye looks almost the same, what we had in the right eye. But when we got the fluorescein, again, that was almost similar what we saw in the right eye. Multiple lesions, pinpoint, we really did not know. However, her IL-10 came out to be elevated. Now, this means it could be lymphoma. I was quite surprised with the results, and they found one atypical lymphoid cells. I still did not believe. I said, okay, now that we have removed Ozurdex, let's wait for 2 more weeks. And this is the vitrectomy I repeated after 2 weeks. No steroids, nothing. Ozurdex is out of the eye. And well, it was lymphoma, mature B-cell non-Hodgkin lymphoma with 70% CD20 positivity. And then I searched the literature. There could be one odd case reported of atrophic lesions in the choroid as first sign of lymphoma. I'm not saying that you see it every day. We do not see it every day. The purpose of showing this case is that if something is atypical, please do not inject Ozurdex or start steroids because they could interfere with the glaucoma and some of these with the diagnosis. And some of these patients, we need to be very careful if we do not understand. The straightforward cases, we just can go ahead with treatment. So choroiditis indeed has many faces and may be masked. And the challenge is to unmask it. How to do it? I think we do not have very well-defined algorithms which will apply to the patients. So each patients need to be mentally evaluated, like what are the pros, what are the cons, where it is, and just keep on working towards revising the diagnosis because the diagnosis would keep on evolving with time. With this, I would like to thank AIOS once again for giving me the opportunity.
Excellent talk, ma'am. As usual, we learned so much from your talk. So I have a question to Professor Amit Gupta. Sir, for our audience, can you tell us that how to differentiate a case of PVRL from the drusen? Like when they are examining an elderly patient coming to their OPD, so how they should differentiate that it's not a case of drusen, it's a case of lymphoma.
Well, Partho, I don't think there can be any confusion between the age-related bruisings, which are mostly seen in the posterior pole, and they will never have vitreous reaction. By and large, when you see patients of primary vitreoretinal lymphoma, you will have a long-standing vitreous inflammation, vitreous cells, which people have tried to treat with corticosteroids, oral, topical, periocular, which are not responding and which is going on and on. So there is so much delay in diagnosing these patients because one doesn't suspect. So in elderly patients, we would suspect if we saw vitreous inflammation associated with these yellowish-white deposits, which Vishali has shown. Plus, they would show what we call leopard skin, or which is very prominently seen on fundus autofluorescence. And if you do OCT, you would see these sub-RP deposits, which are a very, very classic picture, which she has shown, which was quite prominent. These could be very small indeed. So I think these would provide you with a clue on to the diagnosis of primary vitreoretinal lymphoma. And these deposits, remember, they keep changing the shape, unlike the drusens, which don't really show any change in the shape. They may resolve, leaving behind atrophic area and pigmentary changes. You might see, when I talked of leopard skin, they might, even in primary vitreoretinal lymphoma, you would see pigmentary disturbances. And actually, when Vishali showed the picture last patient, I thought we saw something which is looking like retinitis pigmentosa or pseudo retinitis pigmentosa. And in fact, one of the patients which I saw a long time back, old lady, had one eye almost leaving only the posterior pole. The rest of the retina was atrophic. The choroidal atrophy was very prominent with pigmentary changes. And when we diagnosed the other eye with exudative RD and a lot of subretinal deposits, and we treated her with radiation therapy and methotrexate, she ended up exactly looking like the right eye, which was unaffected, had no history, but showed that choroidal atrophy. So choroidal atrophy, as she has pointed out, could be an uncommon sign, but they do present like a picture like pseudo retinitis pigmentosa or leopard skin, which you might see in patients with syphilis, which you don't see in patients with drusen. You would see a little bit of atrophy there. You would see, the drusenoid bodies and with vitreous inflammation, of course. So without that, you won't confuse it with drusen.
Vishali madam, is there any role of MRI in these cases when somebody is suspecting a case of RVNL or?
Yes. Yes, we always do a MRI diagnose it as lymphoma, even when we are suspecting it. The patient with our heme oncologist, sometimes these days they have started preferring PET scan over MRI brain. But this investigation is always done. And if it's a bilateral disease and we do CSF tab, no malignant cell, but IL-10 is elevated, we are treating them now as CNS lymphoma, and we are giving them 5 cycles of chemotherapy for all the bilateral diseases. And if initial MRI is normal, it's important to repeat it after 3 months and then every 3 to 6 months, depending on neurologist's opinion. Yes.
Thank you, ma'am. So our next speaker is Dr. Rohan Chawla. So his topic is, I think I have a patient with retinitis. What do I do next? So over to you, Rohan.
Sorry, can you hear me and see the slides?
Yeah, I can see the slide and
okay.
So
I would like to thank AIOS and Dr. Partho for this invitation. And after this wonderful talk by Professor Vishali, I'd like to add something to it. Madam has already explained a bit about retinitis, and maybe I'll add a bit more to the retinitis for the general ophthalmologists. So the topic is that I think I have a patient with retinitis, and what do I do next? The first thing is you need to realize and you need to pick up the retinitis. So when do you think you have a patient of retinitis? So there can be various clinical situations where retinitis can present. One is you have obvious white areas in the retina. Like Madam showed one case where you saw that lesion of toxoplasma, which was appearing a bit yellow. Typically, retinitis would be more towards a whiter side and the choroiditis would be more towards a creamier or a yellowish side. But yes, there can be some confusion. But there are obvious white areas in the retina with other signs of inflammation in the eye, then I would say I'm dealing with a case of retinitis. But sometimes the inflammation may be intense and then I need to look carefully. And I need to see sometimes that the white patches might be visible either at the posterior pole or in the temporal periphery. There is other types of retinitis where it might just appear like cotton wool spots, but with associated neurosensory detachment, retrodental cells, some amount of disc edema, macular star formation, and some typical OCT features. This is something which we are seeing a lot in our country, which is called sometimes like an epidemic retinitis or a post-fever retinitis. We recently had a webinar on Uveitis Society of India on that. I touch upon that also. And again, if the patient is of unexpected age with a configuration of a detachment which does not normally fit to a classical picture of a rhegmatogenous detachment, then you must search for some necrotic areas or some areas of large tears, which again might give you an idea of whether you are actually dealing with retinitis. So I'll just show you some examples of these cases. So you see this patient here, you have these classic white patches, and some of them are obscuring the retinal vessels. So you know that these are more superficial lesions. There is some vitreous haze, there is disc edema, signs of inflammation in the eye. So there is no doubt that this patient has retinitis. Some other examples, sometimes it may not be that chalky white, it may be more powdery, it may be more granular in form, it may have associated hemorrhages on the surface. So again, white patches with inflammation with various other different entities, which you must consider as retinitis and not primarily as choroiditis. The other thing which I said was when you have a hazy media. So here on the left, if you see, you have a hazy media, but you have a focal single lesion, which more looks like a headlight in the fog. So this would probably, I would think, toxoplasmosis here. On the other side, where you see again intense inflammation, one must turn our indirect and our attention to the temporal periphery. And if you see confluent white patches here, in this case is probably a case of acute retinal necrosis, which is again an ocular emergency and has to be treated appropriately. The focal patches, which look like cotton wool spots, is here in this picture which I was talking about. And these patients again also develop some amount of disc hyperemia and a macular star early on or later during the treatment. Other typical features on OCT which I'll talk about. Here again, if you see carefully, you can see these whitish deposits on the retinal arteries. So these are chiralus arteriolitis, and whenever you see chiralus arteriolitis, you should consider a diagnosis more of a retinitis rather than a choroiditis. So these are the typical OCT findings where you see increased reflectivity of the retina. If you pass it through these patches, you see a neurosensory detachment with some cells inside the retina as well as overlying vitreous cavity. So this was an atypical case of a detachment where the young boy, where the configuration was not exactly fitting into any particular cause, and we also did not find any tear. So then we carefully searched the periphery and we could see these temporal white retinitis patches. And this patient we again diagnosed as having acute retinal necrosis. This patient was recently brought to me, again a young boy having this atypical sort of detachment with areas of thinning and some oblong radial tear, again not fitting into any typical thing. But as the residents slowly give you the history, they then told me that this boy is suffering from choroiditis. Still, this is not very sure of what is happening. Till when I told him to show me the other, and the other eye actually the diagnosis, because here you can see that there is definitely a white patch with areas of hemorrhages. And since this patient is an immunocompromised patient, we diagnosed him as having CMV retinitis, treated him for this eye with the antiviral therapy, and the other eye had to be taken. So now these were the various situations where I told you where you could think of that you're dealing with retinitis. So now what do I do next? So first and foremost, please do not start steroids impulsively here, because many of these cases of retinitis can be infective in nature. So unlike choroiditis, where also, like Madam said, we should investigate and rule out diseases like tuberculosis and syphilis, one must pull in starting steroids definitely once we are dealing with retinitis. Like I said, there can be various possible etiologies, which could be viral, bacterial, parasitic, and also autoimmune in nature. So how do we analyze these cases? Broadly, I would divide them for whether they have large patches involving the periphery and the mid-periphery, or whether they are predominantly focal patches, which are mostly involving the area near about the posterior pole. Also, we need to assess the immune status of the patient, because that could clearly give us a clue to a diagnosis. So when we have a triad of vitritis, circumferentially spreading peripheral retinitis, and occlusive vasculitis, the diagnosis is acute retinal necrosis. So these are the same pictures of the same boy which I showed you earlier. We have these circumferential retinitis, some media haze, We do a fluorescein angiography, you'll see occlusive vasculitis. And here this diagnosis is clinched that this is acute retinal necrosis. Again, the previous photograph, these large circumferentially spreading white patches, undoubtedly it is acute retinal necrosis and we have to start therapy here. So the therapy here is not only aimed at saving this eye, but also at preventing the other eye from developing acute retinal necrosis, which can also be quite common. Rarely you can have a simultaneously bilateral acute retinal necrosis also. So earlier we used to admit all these patients and start them on IV acyclovir for 7 to 10 days, followed by oral therapy, which again lasts for a longer time, for at least 100 days or 3 months. But nowadays, if you don't have the facility for admission, then we also have an alternative of valcyclovir. And I would go for the higher dose. Rather than 1 gram, we would give 2 gram TDS for 3 weeks, followed by a reduction in dose, and again continuing the therapy for 3 to 4 months. Steroids we add depending on the vitreous inflammation, and if there is significant vitreous inflammation, I would add after a few days of giving the antiviral therapy. And like I said, we keep a close watch on the other eye and look for development of areas of necrosis or retinal breaks, which again might need an early vitrectomy. If we have a diagnosis, confusion, or if the patient is not responding as the patient should, then the next investigation becomes PCR of the aqueous, where we would like to rule out herpes simplex virus, cytomegalovirus, and also toxoplasmosis, which can rarely present with these large patches of necrosis. Now, CMV retinitis typically has 3 presentations. Either it is a hemorrhagic sort of retinitis with a pizza pie appearance, or a granular variety, or a frosted branch gingivitis. Sometimes you can also see combination. So this is a frank pizza pie sort of appearance where you have these white patches, some of them are powdery, you have these hemorrhages. So this is, again, if the patient is immunocompromised, most of them are HIV positive, you have a clear-cut diagnosis of CMV retinitis. This patient has a mixed picture. You can see the frosted branch gingivitis as well as the pizza pie appearance in one corner. Again, this patient was retropositive, and there is no doubt in the diagnosis, and we need to treat them, as I'll subsequently tell you. Again, a mixed picture. On one side, you have these hemorrhages as well as the white areas. On the other side, you have only the granular, which is more of a little powdery dusting, not as confluent as the acute retinal necrosis eye. And here you can see the media is absolutely clear. So since most of these patients are immunocompromised, they do not throw up a significant vitreous inflammation. So what will we do once we have diagnosed CMV retinitis? The therapy is oral valganciclovir and started at an initially high dose, and slowly we can reduce the dose as per the response. But valganciclovir is a much more toxic drug as compared to valcyclovir. So we have to be a little careful. We need to monitor the blood counts as well as the kidney function tests when patient is on such high doses. If the patient has zone 1 disease, that is the disease is near about the posterior pole as well, then I would like to supplement the therapy with an intravitreal ganciclovir. Now there were 2-3 doses paradigms given for this, but what now we generally follow is the higher dose, the 6 milligram, because that one we can repeat once a week rather than twice a week. And again, after a few injections, looking at the response, one can go down and reduce the dose and the frequency of the injections. Similarly, again, you have to watch out for the development of any retinal breaks and any thinning. And the heart therapy. In HIV-related cases, there are some papers which indicate that we can stop this therapy once consistently CD4 counts are above 100. But again, you'll have to see the overall clinical picture. In non-HIV patients, the guidelines on when to stop this therapy is not very clear, and we'll have to assess the immunosuppressed state of the patient and see how overall the patient is systemically behaving, and then decide whether we can wean off the patient on therapy or need to still continue some amount of therapy for a long time, low dose therapy. So coming back to the same patient, this is that same ALL boy with the CMV retinitis. In the left eye, now the retinitis has now started resolving once we put the patient on valganciclovir therapy. Now we also have the facility of doing a peripheral OCT here. So once we did a OCT scan through this thin area, we saw that there is a lot of vitreous traction happening on this, and this is a necrotizing retinitis, so a lot of thinning happening. and definitely a lot of traction on this area. And considering that the boy has already had a detachment and probably not going to have a very good outcome in the other eye, we were very afraid that maybe now the child might develop a break in this eye and again a detachment in this eye. So should we go ahead with a prophylactic laser? Now in retinitis, that is very questionable. And sometimes if you hit these thin areas with laser, you might inadvertently create a break and might create a complication. So we have to be very careful here. But since in this patient, the other eye already had a detachment and we saw this retinal thinning developing, what I thought was that I would do a little broader laser just beyond the area of the retinal thinning and just cover it up so as to prevent a detachment. And we did a very wide sort of laser, but I think this has helped the patient because soon later on we saw that there is an operculum here and the patient has indeed developed a large break and again some thinning here, but probably we have prevented a detachment in this eye. Still, yes, we'll need to keep a close watch in this eye. So very carefully one may need to plan laser in some of these cases. Now coming to posterior retinitis, we have a paper on deciding therapy based on the imaging. Now this is something like what madam showed, a typical lesion which has this white fluffy nature and maybe it can have some hemorrhages. Generally, we do not see hard exudates coming up in these cases, but they sometimes can have an exudative RD. And the necrosis, it is also necrotizing retinochoroiditis. It starts from the retina proceeding over towards the choroid, like Dr. Vaishali had said. So, but here the diagnosis is definitely undoubtedly toxoplasma. And even without investigations, one can start therapy. So we can either give oral therapy or we could also give intravitreal clindamycin with or without dexamethasone. Again, in such cases, triple therapy is also recommended. If there is significant inflammation, you could add steroids after few days of the anti-infective therapy. And since it is again a necrotizing sort of retinitis, you do land up with retinal thinning despite therapy. Another classical case where you see the patch of white retinitis developing at an edge of a previous scar. So this is definitely toxoplasma. Even the other eye, like I think Dr. Mudit showed a case, also has a scar in the same patient. So if you have a previous scar, vitreous inflammation and a headlight, again, you do not need to investigate much. And this is probably a case of toxoplasma retinochoroiditis, which you are going to treat with anti-infective therapy. If you do an OCT through these lesions, one can make out that the thickening of the entire retina is hyperreflective and initially it is a retinitis, and you see a gentle bulge in the choroid because the inflammation is now proceeding towards the choroid as well as some vitreous cells over there. So this is a typical investigative picture of a toxoplasma retinochoroiditis. As opposed to this, like which I had shown you earlier, you have the chiaralis, you have these fluffy spots, you have increased retinal reflectivity on OCT and a neurosensory detachment with or without a history of fever. Many of these patients would give a history of fever with or without rash about 3 to 4 weeks prior. But these patients, we diagnose them as having a post-fever retinitis. The causes may be multiple. It is difficult to pinpoint despite serology. It could be rickettsia, Lyme's, Bartonella, or certain other viruses. But like we had discussed in the previous CME, we start these patients with empirical doxycycline because if it is one of these bacterial causes, many of them respond very well to doxycycline. And again, don't start steroids at day one. Start the anti-infective therapy first. And in some cases, you'll see just by the anti-infective therapy, there is a remarkable recovery as you see in this case. But if there is a significant detachment here or a lot of inflammation, you can follow it up with some steroids. And most of these cases have good recovery. Another example, another bilateral case with both the eyes having the same sort of retinitis at the posterior pole, we treat them with doxycycline. And you see over a few weeks to a month, there is a good resolution. And many of these patients do even achieve 6/6 or 6/9 vision if treated appropriately in time. Another variety is where you don't see these fluffy deposits, but it is rather more of a plaque, which might even sometimes give the impression of an arterial occlusion. But actually, if you see, there are cells there, there is a partial hyaloid detachment, total thickening, and areas of necrosis developing in the retina. So again, this eye, this detached because of this necrosis and hole, we lost this eye. But the other eye, you have again that powdery appearance with some golden dust and a necrotizing variety. And here we had empirically treated with valcyclovir, considering it as an herpetic variety. And perhaps we could save the other eye, although the central vision is lost, but the patient still could maintain some peripheral vision. Similar type of plaque here again in the posterior pole. And sometimes in these plaques, since it is a necrotizing sort of retinitis, there is breakdown of the intraretinal vessels and you can get some hemorrhages also. But again, this young boy was treated only with valcyclovir, and slowly you see the response to the inflammation, though definitely the necrosis of the retina would persist. But finally, we will have a sort of a silent eye in this patient. So when you have plaque-like retinitis at the posterior pole, it could commonly be a herpes group of viruses, and we can treat them again empirically with it, even if we don't have definite evidence. But there can be other causes like subacute sclerosing panencephalitis or some other rare viruses. But please, again, do not use steroids in these cases, because then it can become a fulminant sort of retinitis and even spread to the periphery. If you have any doubt, please refer such cases for a detailed evaluation to a retina specialist. Now, we have been talking so much about the infective types of uveitis. Again, this patient shows a single patch of retinitis here with some hemorrhages and some media haze. What would you say? Do you say, is it a toxo? But then if we go a little bit more deeper into the history and the investigations, on fluorescein angiography, I found that there was a lot of fern-like leakage all throughout the fundus here, not just limited to this patch. And also this patient, when we went to the previous records, there was one record of a hypopia on anterior uveitis with the patient in some other patient center had seen. So this patient is more likely an autoimmune like a Behçet's disease, and this would not require anti-infective therapy, but would require significant immunosuppressive therapy. So there can be sometimes a confusion, but since many cases are infective, our first line of thought should be to go out ruling out those diseases rather than autoimmune in cases of retinitis. So first of all, identify that the patient has retinitis. Then, like I said, don't start oral steroids immediately. When there are large areas of involvement and considering the immune state of the patient, the diagnosis could be ARN in immunocompetent and CMV more so in immunocompromised patients. The other possible causes of retinitis are toxoplasma, post fever, and herpetic, like I showed you some examples. Sometimes syphilis and tuberculosis can also present with retinitis, and it can also be autoimmune in nature, such as cases of Behçet's disease. When in doubt, we definitely go for a PCR to rule out these infective causes. And like Madam said, the next line of investigation should always come when you feel your patient is not behaving in the way you feel your therapy should have taken the patient to. And if there is confusion because these are complicated cases, please refer them early. Thank you. Thank you very much.
Thank you, Rohan. You have given a nice overview of the retinitis, a lot of a case example and all. Thanks for your excellent talk. So now we have come to the most exciting part of our event. So where we have selected 3 basic questions which we want to discuss with our expert panelist. And all this question was framed thinking about the general ophthalmologist and how they deal uveitis in their busy day-to-day clinic. So Abhilasha, kindly go ahead with the first question. Kindly unmute yourself.
So the first question is for Dr. Ratinam and Dr. JB sir. How do you order laboratory investigation in uveitis when there is no insurance coverage and cost is a concern?
Can I start?
Yes, ma'am.
Yeah. Actually, as many people, many times we hear the word investigation is tailored. But in my opinion, it is not only investigation, it is the moment you see the patient, everything is tailored. The way you examine the patient, the patient, the way they walk, they sit in your chair, the way they start talking to you, the way you take history, everything is tailored. So when you have a tailored history and when you have clinical examination also tailored, the laboratory examination becomes secondary, or even it is not needed. I'll give you one example. There is a Behçet's patient, typical patient, mouth ulcer, genital ulcer, retinitis patch, and a very typical fern-like pattern, and he is on immunosuppression. And I'm following that patient for 2 years, and every time I see him healthy, suddenly after 2 years he becomes very thin. He's an engineering student, very thin and very tired. The way he walked in, something told me something is going wrong. But he told, I'm all right, I'm hungry. But I suspected tuberculosis. He's on immunosuppression, weight loss. We did CT scan. You will not believe there was cavity lesion. So this is an extreme example where you have to be with the patient. Every visit you follow the patient carefully, then you will pick up the time where you really need investigation. And sometimes you may not need investigation at all. There will be a patient of HLA-B27, the way they walk, the way they sit in the slit lamp, the way they have problem in focusing their, keeping their chin in the slit lamp, everything will tell you that this is only HLA-B27. So in one nutshell, we have to be very, very attentive with the patient on examination, on history taking. Laboratory investigation is secondary.
Dr. JB, sir, your views, please.
So as Ratnam rightly told that from the history, previous records, I go through with very detailed. Most of my cases are referred cases. And what I do is that I come to a focused, short differential diagnosis. And then my laboratory test is no laboratory test to sort of a stepwise laboratory test, which I do. For example, a patient having an fibrinous anterior uveitis recurrent attack, it is so much favor of HLA-B27 positive anterior uveitis. Doing an HLA-B27 will be supportive only for the test. So the treatment part of it, I will start the treatment. But for the infective uveitis, I do not have two different category of investigations, like for with insurance, without insurance. I have got a one shot of investigations, and I don't care that what kind of patients which are saying. I don't compromise with my laboratory approach in infective uveitis in cases or where there is a suspicion of malignancy, like where vitreous biopsy is required, and there is no compromise for me.
Amod Gupta sir, you want to say something?
I think I would like to reiterate what Ratnam and JB have said, that there is no substitute for a good, complete clinical exam. And I must say that the diagnosis of uveitis is by and large clinical. And the laboratory investigations you can do with minimal laboratory investigations, which don't really cost you much money. For instance, you don't have to order, as you rightly said, MRI sacroiliac joint or HLA-B27 when you clinically have a clear-cut evidence of acute anterior uveitis. You don't have to order for PCR in a patient of acute uveitis if you have tested for corneal sensations and you find the intraocular pressure is high. So it gives you the diagnosis. If the patient is not responding and you suspect a viral uveitis, then you would, of course, you have no other choice but to ask for a PCR test. Likewise, you see a patient of intermediate uveitis, and from our experience, we know that half of these patients are tuberculosis. So we will not order a PCR, but we might order a simple tuberculin skin test. We don't have to order a quantiferon test because you can get away by doing a skin test. In an endemic country, if it is positive more than 10 millimeter, it's highly suggestive. So likewise, a clinical exam would give you a diagnosis of toxoplasma, will give you the diagnosis CMV retinitis. Very elegant examples have been shown, in the seminar today. And likewise, acute retinal necrosis or SSP or some such things. The laboratory investigations, very minimal. You can get away and start the initial therapy. But of course, some of those patients would require, like if you're suspecting, example was shown of infiltrative retinoblastoma, you would certainly require a cytopathology, or you want to diagnose PVR, primary vitreous lymphoma, you will certainly like to do a cytopathology of the biopsy, So you can't get away with that, but simple, like ordering a TPHA, because syphilis can mimic any, ordering an X-ray chest only if Montus is negative, to demonstrate a hilar lymphadenopathy. You don't have to order a CT chest to diagnose, sarcoidosis. A negative Montus, in our experience, was far more discriminatory than, looking at the CT chest when we were comparing the two. So I think we can get away by ordering very simple tests if required. Otherwise, by and large, I would say your diagnosis is clinical, and clinical means not only slit lamp exam, a good slit lamp exam, but also a dilated fundus examination. If you have not done these, then you have not conducted the examination for a uveitis patient.
Thank you, sir. Thank you, Dr. JB, sir, Dr. Ratnam, madam, and Amol Gupta, sir, for the very practical tips. So to summarize, clinical examination is the key, and do not worry too much about investigating these patients. We'll move on to the next question. This is for Dr. Vishali, ma'am, and Dr. Amol Gupta, sir. How do you select imaging for uveitis when there is no insurance and cost is a concern? Dr. Vishali, ma'am, first.
I think we are moving in the same direction. When we hear in the meetings and conferences, all of us, what we are showing are actually 10% of the uveitis patients. So we end up using this term multimodal imaging, which means probably the attendees get an idea that we do everything for everybody. And recently, I have really started talking about customizing the imaging, tailored imaging, not only tailored labs. For example, I showed a patient where I looked at it and I thought it could be a leopard skin. Now, I just need an autofluorescence, whether that is based on the camera or SLO based or whatever I have, to look at that leopard skin. After that, my next thing is I want to look where the deposits are. So I will do the OCT, but I have to make sure that my OCT line scan passes through the lesion, because normally what people do is a cube through the fovea and the center, which really doesn't pick up the pathology. So line scan passing through the lesion, and if I see the deposit is subretinal, I honestly do not need any other imaging modality. Rohan showed acute retinal necrosis, CMV retinitis, toxoplasmosis. I will not do any imaging except the fundus pictures where I need to monitor them as to what is happening. And, I will not do any labs also, like serology is overrated, and many patients are carrying a huge serology for rubella, for God knows what all, So serology is not helpful in decision-making, nor is the imaging, unless you are doing a customized imaging. ICG, I do. Like if it's an honest case of VKH, I do not need ICG to show me. But if it is something where I'm not very clear, I want to study the choroid has the granulomas or choriocapillaries or something, I would do ICG, but not everything for everybody.
Yes, ma'am. Thank you, ma'am. Dr. Amod Gupta, sir, your views on that question?
Oh, let's look at, like Vishali said, I'll just like to give you one-liners on that. Say confocal specular microscopy. Okay, Padma Malini is such an expert, but I would order only if I'm seriously suspecting CMV anterior uveitis. Only then probably it plays a role. Otherwise, I don't think it can tell you any good information. Like UBM, if I have a patient of JIA and the patient has a hypotony and I want to know what's the cause of hypotony, is it ciliary atrophy? Is it a ciliary detachment? Is it a cyclitic membrane which is pulling on the ciliary processes? It gives you vital information. Rest of the cases, I would not order a UBM. Like OCT, if the patient has subnormal vision and there is, you want to diagnose CME, for instance, or you want to see whether there is a foveal atrophy, or you want to know whether there is a CNVM developing there, then you would be ordering or an epiretinal membrane. You will be ordering an OCT. So you can't diagnose any of these confidently unless you do an OCT. So there has to be a strong suspicion, like OCT angiography, so much talked about these days. I would order only if I am suspecting a macular neovascularization or MNV. That is, patient has a sudden onset of floaters. He has had some healed lesions or active lesions. He has had healed choroiditis or PIC lesions or serpiginous-like choroiditis or serpiginous choroiditis, or has VKH or sarcoid lesions. There, I would suspect that patient is developing macular neovascularization, and I would OCTA angiography is a non-invasive test and will help you there. Fundus autofluorescence is a good way of following up your patient. All patients of posterior uveitis, I would like to do an ultrawide if available, or at least some fundus imaging. If you have multimodal imaging, well, it helps, but it's not critical to diagnose these patients. Okay. For instance, if you are suspecting acute macular retinitis or AMN, acute macular neuroretinitis, then you will infrared reflectance would give you the diagnosis. Fundus autofluorescence would give you the diagnosis of Mute's lesion. Mute's lesion would be diagnosed so well on fundus autofluorescence. Serpiginous-like choroiditis, which otherwise is very difficult to tell whether it's active or inactive, you would be able to tell on fundus autofluorescence. So very targeted imaging I would use. Now, invasive tools like ICG, for instance. Now, if I'm confused between a VKH disease or a CSR or CSCR, okay, if I'm confused between the two, I'm not able to decide, and you want to start treatment, I would do an ICG. Or say, I have a patient of, say, sarcoidosis, or is it birdshot choroidopathy? There again, ICG would perhaps be helpful in making a diagnosis. And fluorescein angiography, I would order for, vasculitis patients. If you are trying to assess for capillary non-perfusion, if you are not very sure about retinitis versus choroiditis, or there is a choroiditis and you want to know, probably the FA would serve the purpose. Otherwise, probably it doesn't serve any purpose. So these are some of the, each investigation modality just must provide you with an answer, yes or no, and you must, have a differential diagnosis, what you expect from that imaging tool. Except that, well, fundus imaging, just to know whether the case is progressing or responding to your treatment. Without imaging, you will never be able to tell whether patient is responding to treatment or patient is getting worse on your treatment. So for talking to the patient, you can show him the pathology, you can tell the urgency, you can show the response either way, and patient would be, for your he will be coming back to you because he understands now what are the stakes as far as vision is concerned. So imaging has a role, certainly has a role. non-invasive, most of them, but only very targeted, not shotgun approach that you order all the tests.
Thank you, sir. Thank you, ma'am. I think it's a very important point you have highlighted. I think also FFA is very important in ruling out CSR in some cases of exudative also.
That's right.
When before deciding the treatment with steroid. So we'll just go to some tricky cases. 2 questions we have on difficult situations. So we'll go to Vishali ma'am first. A 57-year-old patient with bilateral choroiditis have been treated with 6-month anti-TB therapy 10 years back. His quantiferon gold and Montu tests are positive, and his CT chase shows evidence of healed infection. What will be your approach? Repeat ATT, look for multi-drug resistant TB, treat it with immunosuppressives, or look for TB on vitreous biopsy. Ma'am?
So the first and the foremost thing is you look at what kind of multifocal choroiditis it is. It may be that the multifocal choroiditis has a phenotype which is not suggestive of tubercular multifocal choroiditis. So every multifocal choroiditis, if positive for TB, does not need to be treated for TB, because we do have multifocal choroiditis of non-TB origin. So there has to be something very specific about the phenotype which convinces me, well, it could be TB. Now we come to that situation where we have ruled out every other etiology and we still feel TB is responsible for the recurrence. Coming to multi-drug resistance, if something has remained quiet for 10 years, then it means it did respond to the initial therapy. So we are not discussing multi-drug resistance here. And coming to the vitreous biopsy, I think whenever I do imaging or I do investigation, I ask myself question that what is my question? What is the answer I'm seeking for? So why I am doing vitreous biopsy? Is it just to do the PCR for Mycobacterium tuberculosis? Well, if that's the case, it's just going to be 30% chances that I will get a PCR positive, because that is the best positivity in our hands. So honestly, I will not do an invasive procedure like vitreous biopsy just to get a PCR for TB, because here I'm sure that this is nothing else but probably TB. Now coming to the rest of the 2 questions, number A and C, do I repeat anti-TB treatment, which means am I suspecting reinfection? And the second is number C, am I suspecting that it could be an autoimmune response to Mycobacterium tuberculosis? To me, things are in a way simpler. I'm not a basic scientist, so I don't go much into it. I'll tell you in practice. I will start, if it is just the anterior uveitis, you start topical and there is multifocal choroiditis, which is in the periphery, which is not serpiginous-like. I'll be very happy treating this patient on initial steroids, adding immunosuppression, and see how the patient is responding. If the patient is not responding, or if some signs comes, like posterior synecdoche, some signs which tell me that it could be tuberculosis, and the response to immunosuppressive is not as good, I will think of adding ATT. But I will not just jump guns and keep on adding ATT every time I see a recurrence of inflammation.
Thank you, ma'am. Thank you. I think you explained it so nicely. I think that will, there are a lot of confusion among the general ophthalmologist and even UVS specialists that how to treat such cases. I think you provided a great overview. Professor Amod Gupta, sir, you want to add something?
No, I don't want to add, but it's not a simple algorithm here. It's a very, very challenging situation, and it's a real world situation what you have posed, because many of these cases they do present with past history of taking very effective 6 months or whatever duration of anti-TB drugs. one thing we have learned from basically the work from Soumya Vasu lab, and that is the most of the response in TB uveitis, at least in choroiditis, is mediated by autoimmune reaction, because he did find autoimmune response to both the retinal antigens as well as the TB antigens. So there's a mixed response. So there is a TB infection plus a predominant lesions are caused, predominant reaction is immune mediated response. So as Vishali said, we would perhaps be wise to start with corticosteroid therapy, and patients we expect to respond. But at the same time, once there is a healed lesions in the chest and we are putting the patient on corticosteroids, I think it may be wise to look for any systemic reactivation of it's a real challenge, because you might reactivate a healed focus of tuberculosis, because TB eliminating it from the system is well nigh impossible. So there might be lying somewhere you might be reactivating. So without monitoring the patient, I think you shouldn't proceed. You must monitor the patient so long you are treating it. And as far as the reoccurrence of these lesions, now we know that in tuberculosis, it is a reinfection, because for a patient, nothing has changed as far as the environment and his living quarters are concerned. He's living with the same people, moving around in the same milieu. So it's not recurrence of this lesion or recurrence of the pre-existing tuberculosis. It's a fresh infection. Okay. And anything that you see after a couple of years or 18 months or so, it's a reinfection, it's a reintroduction of the organisms. So that also you have to keep it in mind, when you are dealing with this kind of situation. And that creates confusion. Should we do the anti-TB drugs again? So nobody has that answer as yet. I would say that. But you keep eyes and ears open and be vigilant, and if required, don't be hesitant to start. Also remember, the 5% of systemic TB, or 5 to 8%, is because of MDR, and it's a real issue. But as Vishali said, these are the patients who will continue to have inflammation. They will not show a period of several years, healed lesions, and then suddenly becomes active. No, that's not a sign of MDR. MDR would mean that the lesion activity is continuing while under treatment with the regular conventional anti-TB drugs. So I would not consider that. But in our own experience, I think close to 12 to 14% of the patients of TB uveitis did harbor resistant organisms, and they did respond to the MDR treatment. Finally, to the need for vitreous surgery, I think Basu has shown, and so have we seen in our experience with vitreous surgery itself, could lead to resolution or resolution of these choroiditis lesions. So if you look up his paper as well as from our own experience, we have seen right from day one, it has a tremendous beneficial effect by removing the cytokines load or whatever, which keeps the inflammation in a perpetual mode. You remove the vitreous and they start healing. And we have seen in the series we reported 110 eyes or something, the lesions, the vision starts improving, the lesions start healing, and so it does have a beneficial effect if you do vitreous surgery in these eyes. So each of these has a reason for doing, and I think it's a very, very valid question, but $1 million question. Nobody has the right answer.
Thank you.
Yes. I would just like to add, like Sir said, that only thing is it's autoimmune plays a very important role. So even if we are thinking of adding ATT, even if we are repeating, by and large, these patients do not respond to ATT alone. So it has to be combined with number C. So number C is always required. Steroids and immunosuppression with or without ATT is, of course, $1 million question.
Thank you, ma'am. Thank you, sir. So we will go to last question of the day. So I'll start with JB, sir. So a 28-year-old patient with pars planitis, a steroid responder, is on maximum immunosuppression. He has unilateral cystoid macular edema with a central macular thickness of 850 micron on OCT. So what will be your approach? Do nothing, intravitreal dexamethasone implant administration, intravitreal triamcinolone, or you will treat with topical NSAID? JB, sir?
Yes. I would, the first question, do nothing is not comes at all. I will not give intravitreal dexamethasone implant because he is a steroid responder. And intravitreal triamcinolone also is around. I'll try with the topical NSAID first, and if not responding, then I will consider giving an intravitreal Ojudex, that's the dexamethasone implant, because the chance, even if it's the rise of intraocular pressure is high, that's controllable with anti-glaucoma medications very well. And you do not require anti-glaucoma surgery in such cases. With such thick CME, if it doesn't fail to respond to topical NSAID or immunosuppressive medications, I will consider giving intravitreal dexamethasone implant with caution.
Okay. We'll go to Dr. Ratina. Ma'am, are you there?
Yeah, I'm here.
Yeah, ma'am, can you give your opinion in this
Yeah,
case?
I do agree. Because it is 850, I will go for intravitreal dexamethasone implant. I will be ready with the treatment with my glaucoma specialist. Because, of course, we do have very good medical treatment, very good surgical treatment. And this 850 is little too high. So do nothing, do not come here at all. Topical NSAID usually works till 300 or 250, something like that. 850, as Dr. Biswas sir said, intravitreal dexamethasone implant is the best. But we do have glaucoma treatment also.
Vishali, ma'am, you have any take on?
I think I would look at the IOP. What do you mean by steroid responder? Was it in 20s? If it was in 20s, like Dr. Jamie and Dr. Ratinam said, I will be very comfortable adding anti-glaucoma and try Dex implant. But before that, I will do OCT to rule out any tractional component. And sometimes, even if there is no traction, on swept source, you can beautifully see there is a precortical pocket. Now, that is the pocket which is, is a reservoir for a lot of cytokines there, and you need a very strong dose of steroids or whatever treatment to take control. In that scenario, in this particular patient, I might just do vitrectomy to release that vitreous, clear off all the cytokines, and then manage it. We are coming up with the results of 24 weeks of MERIT trial. Anti-VEGF and methotrexate really does not work. It's only the Dex implant which works for uveitic macular edema, probably because of the cytokines. So it's a tricky situation, but I think it will be combination of vitrectomy if required, Dex implant, depending on the initial pressure which it was.
Ma'am, many ophthalmologists think that anti-VEGF can be a suitable option here. Do you agree with that?
Anti-VEGF, that's what I'm telling you. I mean, Hopkins group did MERIT trial. I'm a part of it. So the manuscript for 6 months follow-up is going out now. So anti-VEGF, even the initial experience came from Nisha Acharya. Nisha is leading this MERIT trial also. In the trial setting, anti-VEGF was not found to be effective in the management of uveitic macular edema. So we compared Dex implant, intravitreal methotrexate multiple injections, and intravitreal anti-VEGF. It's only the Dex implant are the patients where the switchover was done to Dex implant are the ones where macular edema truly responds. The others were not found to be statistically, or even non-static, were not found to be of help. So I would rather clear the vitreous than keep on injecting anti-VEGF, because it's a lot of injections, 850 micron is not going to respond to.
Very, very good, very good. Over to you, Abhilasha.
Yes. To summarize, we had a very good clinical discussion and very practical tips from all the chairpersons and speakers. I thank you all for your efforts and your time today. And I also thank the AIOS team, Dr. Santosh Unawar, as well as Dr. Manoj Mathur, for this opportunity. I hope we all learned a lot. And thank you and good night.
Night.
Good night.
Night. Thank you.
Nicely
Thank you very
organized.
much.
Thank you. Nicely organized, Partha and
Thank you.
Abhilasha.
Yes.